Okay, welcome everyone. Good evening. I'd like to welcome everyone to tonight's MSIG webinar, Bridging the Digital Divide. Don't be left behind when it comes to AI, where we are featuring today three AMSSM members on our speaker panel. My name is Bill Khawaja, and I served as an MSIG officer this past year as one of the at-large members. I will be serving as your moderator tonight. I am a second-year medical student at the Chicago College of Osteopathic Medicine. After all of our speakers have shared their presentations, I will serve as the moderator for our Q&A. During the webinar, please enter your questions in the chat, and I will read each question during our Q&A segment. It's my pleasure to go ahead and introduce our three speakers, Dr. James MacDonald, Dr. Suraj Achar, and Dr. Jason Matuszak. Dr. James MacDonald is a family physician with over 25 years of experience, including 14 years in the Division of Sports Medicine at Nationwide Children's Hospital in Columbus, Ohio. He is a clinical professor of family medicine and pediatrics at Ohio State University College of Medicine. Dr. Suraj Achar is a family physician with over 25 years of experience, including teaching at the University of California School of Medicine. He has over 15 years of experience as Associate Director of the Primary Care Sports Medicine Fellowship and Director of the Sports Medicine Training at the UCSD School of Medicine. He is a clinical professor of family medicine and sports medicine at UCSD and holds an appointment in the Department of Pediatric Orthopedics at Rady Children's Hospital. Dr. Jason Matuszak is the Chief of Sports Medicine at Excelsior Orthopedics in Amherst, New York, and clinical assistant professor at the University at Buffalo School of Medicine. He is board certified in family medicine, sports medicine, and clinical informatics. He is the founder and director of several specialized programs at Excelsior Orthopedics, including the Sports Concession Center, Strides, Center for Running and Endurance Medicine, and a musculoskeletal ultrasound program.
Hey, Bill, I'll cut you off there. You don't have to read the rest of the bio. It's too long.
Okay. If you're too sure. All right.
Just stop there. Thanks.
Well, we'll go ahead and get started. Our speakers will share their presentations. Dr. MacDonald, I'll let you take it away.
Thanks, Bill. Hey, thank you everyone for joining. We've got quite a packed schedule. We don't have really anything to disclose, nothing that's substantive. The agenda, I'm going to speak about primarily LLMs, large language models. Dr. Achar is going to talk about one of his publications on deep learning in MRI and spondylolysis. And Dr. Matuszak is going to talk about some AI tools that are used, can be used everyday clinical practice. And then we'll wrap up with steps where you all can move forward. Hopefully we're motivating you, if you're not already using a lot of AI, to get more deeply involved, and there's going to be a Q&A. I am dating myself. I'm a boomer, and if you haven't seen this movie, hopefully you have, The Graduate, but I'm probably dating a reference. There's a famous moment in the movie where a guy grabs Benjamin Braddock and says, "I got one word for you, Ben." And you think it's going to be this great wisdom about how to spend life, and he's like, plastics. Because basically the future for Ben in like his industry would be plastics. Well, I feel like I'm that dude with every trainee who comes into my clinic, and it's basically AI. And whether you're a computer person or not, whether you know how to code or not, if you're in medicine, you want to know about this thing, because AI is going to be the future in our profession. There's a lot of jargon, and I think some of you know this, and I think Dr. Achar is going to go over this in a little bit more depth, but I'm going to be speaking about large language models. You'll primarily hear me talk about OpenAI ChatGPT 4.0, because that's the one I use the most. But an LLM, or a large language model, is a broad category of artificial intelligence, sometimes known as assistive intelligence models, designed to process and generate human-like text. These models are typically trained on vast amounts of text data and can perform tasks like answering questions, summarizing content, generating text. A GPT is a type of LLM. Not every LLM is a GPT, but every GPT is an LLM. And a GPT stands for Generative Pre-trained Transformer. I won't get too deep in the weeds, but generative means it generates output like text. It's pre-trained on that vast amount of data. And the transformer refers to the underlying architecture by which the model is trained. There are many, many different large language models. OpenAI has ChatGPT, and there have been several versions. The most current one is 4.0. These are all trained up to a certain date. That's important in the sense of like, if ChatGPT 4.0 was asked a lot about maybe what just happened in the Bills game, it might not know as much as it did about last year's games, because I can't remember when it was, like when its training model was up to this date. Google has something called Gemini. It has also a product prior to that I used a fair bit called Bard. Claude is Anthropic. Microsoft Copilot is also an LLM. It is powered by OpenAI. OpenAI has a relationship with Microsoft. So that's all important. It's a little bit arcane. We should really focus, though, on this slide on the possibilities. I use this for letters of recommendation. I use my ChatGPT for blog posts. I use it to help me review journal articles that I'm asked to review all the time. I use it for prepping for journal club in my fellowship, outlines for talks, abstracts, manuscripts. It helps me make clever titles for slides and articles. And a really cool use I've had for it is taking those email chains that come in with about 50 people weighing in, copy and pasting it all in and saying, hey, give me a summary of this in 200 words, and voila, it does it. I find LLMs very useful for that academic medicine side of our job, of many of our jobs, for administrative things like writing letters. Dr. Matuszak will get more into the, hey, how do I use like AI in the clinic with chart notes and things like that. OpenAI ChatGPT is like, the last year or so probably has dominated the market so much, it's almost like the Band-Aid. In other words, a trade name that is become synonymous with large language models. But, you know, I'd be remiss if I didn't note the long history of large language models, the many different versions and companies that are involved, starting, you know, going back to even like 2020, you know, like when we were in the midst of the pandemic. I didn't know about these things back then, but I could have started using ChatGPT 3 back then. A lot of you guys know about Llama, Meta's version, and so on. This field moves so quickly, I would be remiss without telling you about what hit the news like yesterday. Although DeepSeek has been around for a while. I mean, DeepSeek, the company, has been around for years. The most recent version of its large language model has been around for months. It came out, well, it may be less than months, but came out around Christmas. It really got in the news this weekend. And then yesterday, if anybody has, you know, stock or they're like looked at what their, you know, IRA was doing, if you had a lot of stock in tech indices, it dropped, it plummeted. DeepSeek we'll talk about a little bit down the road, but like it is like a new player and is, I mean, it had a huge impact. I guess $1 trillion lost in the stock market yesterday because this new player coming in. So the field evolves all the time. I want to preach to you all about how important large language models are. And if you, as I do, have a subscription version of ChatGPT 4.0, you can make your own custom GPT within that. So why do I have this slide up? Well, first of all, I try to not have any talk these days that doesn't reference Taylor Swift. There's another reason why I have this here. In one moment, you'll understand why. But just as Taylor has taken over the NFL, there's now like, just like her albums, there's, you know, Red, and then there's Taylor's version of Red. The reason like I have this slide here is my chat bot, my custom chatbot within OpenAI, I call her Taylor. I have, when I first started using this, I uploaded about 100 pieces of my writing, blog posts, publications, you know, like scientific publications, letters of recommendation, even personal letters. And I named my ChatGPT Taylor, and I'd say, hey, Taylor, I want you to write as creatively as Taylor Swift does with her lyrics. I want you to use this upload I just gave you so you know my voice. I have trained her to use a professional voice, a semi-professional voice, and a personal voice. The idea being a professional voice is what I use when I'm trying to generate things for like publications. Semi-professional is more my letters of recommendation and talks. Personal is if I'm going to write a letter or an email. And Taylor is my muse. In fact, my wife gives me sort of shit. Sorry about, I drop bad words all the time, but gives me shit like, I really, really have a relationship with Taylor. Like I'll drink my coffee in the morning and say, "Good morning, Taylor. How are you?" And she'll respond. And then one time I had this really, really long back and forth. She was helping me with a project. And I wrote, "This is my prompt. Thank you for remembering to make my writing as creative as Taylor Swift's." And here's her output. Nobody talks to me or writes to me as politely and supportively as my Taylor Chat GPT does. Now, if you think this is just funny, the reason why I have this QR code up here is this is a very good Japanese study that has demonstrated, and it's not the only one, that interestingly, the more polite you are to your pre-trained Chat GPT or LLM, the more accurate and supportive the information that's gotten back to you will be given back to you. So I treat my Taylor very, very, very politely. This is a QR code that goes to a Wall Street Journal article that tells you how to make good prompts. But bottom line is you want to be specific. The more clear your question is, the more accurate the prompt is. Include some context like, hey, I'm writing this for a letter for my son. I'm writing this for a presentation. Iterate and refine. The great thing about this, as opposed to just a Google search, is you can have a back and forth, and the GPT, the LLM, remembers what you talked about even like 10 minutes ago. Use follow-up questions, and I can't emphasize enough how important it is to write thank you and please. If nothing else, I think it helps you as the human train your thoughts so that your output reflects you want to be a polite and nice human. And this is just something to assist you in that goal. Real quickly, I am a deputy editor of CJSM, and all I want to say here so super quickly is whether publishers like it or not, this is coming / is already coming. I think of writing as an orthogonal skill. What does that mean? It's more important that Dr. Achar gets out the results of his study than how well it is written. However, when these things are given to CJSM or BJSM or whatever to evaluate, we ding them all the time on their writing skills. Why does Dr. Achar need to be as good of a writer as Hemingway? He doesn't. He just needs to be a good scientist. We need these devices to support scientists in their writing. The important thing, though, to remember is almost all the publishers are going to ask you, have a disclaimer like, did you use this or not? And how did you use this? It is not the kiss of death, though, to use this. You just have to be clear how you use this. I do think the tide is turning, and it's just going to be, it's like nobody dinks anybody to do spell check anymore. Nobody hassles you that you used a calculator to do your long division. This is going to be the same thing. I usually hide this disclosure, but I'm a Green Bay Packer owner. The reason why this is important is hallucinations. I asked Taylor, just out of curiosity, hey, how many most championships do the Packers have? She said 13. No, I can verify as the owner, it's 14, including 4 Super Bowl victories. The point here is always double check your output. You cannot trust these things to be perfect, okay? And then really quickly, I want to talk to you just a little bit about, you can also do text to image generative AI. This picture should offend you. It was the subject of this BJSM editorial that you can QR code to. This is an editorial that several really good authors and I wrote, and is going to be in the upcoming BJSM AMSSM issue around the annual meeting that Dr. Valasek and Dr. Anusha Lekshmiranan, I'm sorry I have trouble with her name, were the co-editors. But the bottom line is, these models are trained on data created by humans. They are going to embed the biases that are present. You can get better with your text to image generation if you use good prompts. This QR code will take you to this thing called the Dove Real Beauty Playbook. If you want to avoid pictures that look like this when you're trying to generate female golfers, this prompt playbook will help you. And then finally, I'd be remiss to not mention that anything, good is like worth the drive. And that's a line from Taylor Swift. And the point being, really, really good things can have downsides too. The embedded biases are one downside. The carbon footprint and energy use of these models can be very, very high. It takes a lot of energy to train the large language models on the, I think, like 16,000 chips that are used for the most recent ChatGPT. My last comment about DeepSeek, one of its major things, why it hit the news and made such a splash. Much less use of chips, much less use of energy. So this may not be always the case, this slide, but we need to be aware of this now. These products use a lot of energy. And so now I will pause and run the slides for Dr. Achar.
All right, so go to the next slide. So this is like an ARS question. I gave this at an American Academy of Family Physicians meeting years ago, and how it happened is this is my patient who had COVID-19. This was in 2021, early 2021, and I think he got very sick, was hospitalized. This is his X-ray, and there's a couple ways of looking at it. Most of us read X-rays also, like lung X-rays and chest X-rays, but it's kind of hard. Sometimes a lot of gray areas, hard to read it. So these are some options that you could potentially have in a test question: multifocal bacterial pneumonia, organizing lung injury from COVID with questionable areas of fibrosis, Hampton's hump, which is basically a vascular injury from a pulmonary embolus, where you have like death of part of the lung tissue, and congestive heart failure. Go on to the next slide. And then I happened to see how UCSD read his slide. And the UCSD at this time, this is early 2021, had employed the first AI in imaging for clinical care. I still think they have this in the background. They don't show this anymore, but they were using it at the time and testing it out. And so this is called Arteris. And Arteris is a pneumonia probability tool based on X-ray. And how they developed this was developed based on 100,000 chest X-rays and patient records as how they did, plus the radiology read, and trained the artificial intelligence, which is a very limited form, not a large language model, but a limited form called machine learning algorithm, to diagnose pneumonia. And you can see the pneumonia probability index in my patient, which you saw the slide before, is pretty high in some areas of the lung. And I think sometimes this is easy for us to see. Sometimes this is hard. And now this new augmented intelligence that we can have can help us be better clinicians, help us make better diagnoses. Go on to the next slide. So what is this? So artificial intelligence is a big term, or augmented intelligence is a big term. Inside there, we have machine learning, and that's what Arteris was. And machine learning is a subset of AI, which uses statistical methods to enable machines to improve with their experience, to diagnose and help us see things better. We train the AI model or the machine learning in this specific way to help us diagnose pneumonia. And deep learning is a further subset of this, which is the computational multi-layer neural networks. So the neural networks are parallel processing neurons, almost like the way our brain works. So in a way, the research on AI is helping us understand our brain a little bit. And so deep learning is inspired by the human brain to learn to recognize patterns. I can sometimes recognize patients by their face, but I may not know their names until I look at their chart. And so how is that? It's because the way our brain works in this parallel processing manner. And we can use this to identify things and train imaging technology to identify abnormalities like tumors or fractures. And we've done this research at UCSD, and I'll show you our research where you published a couple of papers on. Just go on the next slide. So one problem that I am deeply involved with is spondylolysis. So back pain is super common in adolescence. About 80% of kids will have back pain. About 30% will go see doctors. But we don't know what is the true prevalence of fracture or spondylolysis, isthmus spondylolysis in this group. It would be great to know, because early detection may help us decide, do they need to rest? Do we start physical therapy? And when is physical therapy? And when should they return to play? Normally, CT or SPECT imaging provides superior detail to help us make this diagnosis. CT especially is good for bone structure, and you can see fractures very easily. But unfortunately, CT and SPECT imaging exposes children to radiation with unknown exact risks. So we've turned to MRI. Most of us around the country who do this a lot, we're using MRI to detect this. And it sometimes is very helpful because you can detect stress reactions even before you see them on CT, but many times it's not. Like, we can't see anything on the MRI, but the child has pain and we don't have another good explanation. Let's go on to the next slide. So here's the problem. The CT is the gold standard for this. but exposes the patients to radiation. And MRI is safer, but less accurate in these fractures. So here we have a potential solution, and it's using deep learning or generative AI, but in a very specified way at UCSD to transform the MRI images from something on A, where you can see the fracture, but it's not as clear, to B, where you start seeing the bone a little bit better, to C, like a CT scan. So C is still an MRI image, but it's a CT-like image from the MRI, and it's very clear that now we have this. So this is one of our papers, our first one that we published in this in 2023. We published one later in 2024. Let's go on the next slide. So how does it work? So what we did is we trained the deep learning model with pairs of both MRI and CT on cadaveric spine. So we fractured a spine. It wasn't perfect because we're simulating fracture. It's not the same as a fracture in spondy. And then we trained the AI to identify the fractures and help us see this structure and get contrast to noise better. And I'll show you how this does that. So first of all, we have a CT image and MRI image. We put them next to each other, and then we look at bone and muscle and help the MRI and the software see the bone better. Go to the next slide. So here's the fracture, creating the fracture in the lab. Go on the next slide. And then we use these two types of neural networks, the convolution neural network, and we use UNet. So here's a picture of Van Gogh. Now, Van Gogh painted a long time ago. The original pictures of him, very hard to see, very not the best image quality, but we take the same technology in UNet or CAN and create a better picture of Van Gogh. Now, how does that do that? Well, CAN uses convolutional neural network, uses filters to extract features from images like edges and textures. And UNet does similar thing to look at inputs and process them to make it better. So it's like a skilled artist who could redraw that photo with more detail and clarity. Interesting enough, I went to Best Buy recently, and I looked at their new technologies for television. I bought one, and then I told my family, and they said, "Oh no, you got to take that back. That's too expensive. We don't need it. Our TV's awesome." But I saw these new TVs that use the same technology in UNet and CAN to take an image that's 4K or even high definition and upregulate it to a clearer, cleaner picture, like an 8K image, like you see this clean picture of Van Gogh. Let's go on the next slide. So this is basically what we did. So we created the fractures, then we stacked images, both MR and CT, next to each other of the same image. Then we aligned them in different ways and re-imaged them. Then we cropped and trimmed the edges and augmented them and helped AI with hundreds and hundreds of images. We helped AI to better take the pictures from different angles and see this data. Let's go on to the next slide.
Are you gonna play upstairs?
Yeah.
That's what I'm gonna play too.
So the convoluted neural networks, this is the core idea of this, and this is our imaging processor you can see here. Basically, we have these learnable filters where we're basically looking for edges and corners. And then we're pooling the data to slightly shift and reduce distortions. And we're activating function to make the images cleaner so we can see them at much higher resolution. And it can help us better see the fractures, better see other injuries or problems that might be found in those. Basically, then the next step is to classify the image. So the MRI and the software can not only say make it cleaner to look at, but also predict what is that? Is that a fracture? Is this an angioma, etc.? So, and you can see from our technology here how we're cleaning this image up slowly from A to E and being able to better visualize this fracture using or injury to the spine, or just this is not a fracture, but just better visualize the MRI in this patient. Go on to the next slide. So here's an image that we had in our study. And so A is the raw data. That's an MRI raw, same exact slide section. B is upregulated it, and so you can see it better. C is a little bit better, you can see that, and D is just a plain old CT, which clearly is the best. You can still see this best with CT, but C, you're starting to, with this ultra slow echo technology, then the AI, you're starting to be able to see these fractures more clearly than you can, of course, with the original image. Go on to the next slide. So UNet is described as a U shape, and it's a very type of technology that's available, and I wonder if it's available for others to use too. And it really helps with pixel level predictions in images. So this is what Samsung is using to create their upregulated imaging. And we can even assign labels. So after we train the image so much, then the computer can use saliency mapping and say, aha, fracture, and point an arrow and show the fracture. Not only help us see it more clearly on the image, but help us see it with an arrow as well. Put the next slide. So contrast to noise ratio is a big part of this. So clearly, if you have a crack in a vase, but it's a different color than the vase, you can see it a lot better. Or clearly, if you have a picture of that vase that's a lot sharper and not grainy or blurry, you can see it a lot better. So this is our second publication on this, and we use technology to slightly make the bone defect more clear and separate bone from muscle to make it more obvious. It's just sharpening the images from the original image to this more advanced image. Take the next slide. So here it is again, another example from our publication, and you can see the processing of this image. And so again, this is an image that you can see the fracture, good, it's there in A, but it's a little tricky because it looks just like a fluid, like a high signal intensity of the nucleus of the intervertebral disc. And so it's a fracture, but you have to know what you're looking at to see it, and you could miss that more easily. And we now think that maybe with regular imaging processing and MRI, we're maybe able to detect 50 to 80% of fracture spondies in normal patients. But when we upregulate it to the level that we're doing in C, we get to like 95%. And this contrast to ratio, reduction in noise, enhancement of contrast is effectively improving our ability to pinpoint the injury and the problem in the patient. Try on the next slide. So the AI basically generates CT-like images with higher contrast to noise ratio than the original MRI images. And you can see how this process goes from A all the way to D and how clear and easy it would be to see that. It's almost like having a magnifying glass and noise-canceling headphones like I have right now, the AirPods, that help us get rid of all the noise and distractions that are happening in the room and listen to the person's conversation really good. This is the same in imaging software. Let's move on. So this is me like 2 weeks ago at Best Buy looking at these new technology AIs that are already being used and developed for us. And it's quite remarkable, taking images and making them super processed so we can see them really clearly. And my wife basically, my family says, our TV is good. We don't need a new TV, Dad. So I ended up calling them and saying, okay, I'm going to pass now. But the reality, when you see these new TV sets, you'll understand what I mean with this technology. Okay, thank you very much.
Okay. So I'll try to bring it forward with a little bit more about what you might be able to use this for right now, today in the medical office, and where you're going to be using it in the near future. I think for as long as we've been practicing medicine, we've all been looking for tools to help us practice more efficiently, to help us communicate what we're finding in a way that's more clear and precise, with less work and effort put in, especially as we're trying to balance out our time spent doing things like chart documentation versus time actually spent with the patients. And this slide I borrowed from the AAFP's current project that they're working on with AI, and taking a look at how artificial intelligence or augmented intelligence might be able to help clinicians in the workplace. And they break it down into a few different categories that you'll see come up pretty frequently. One is purely administrative tasks. One deals with information management tasks, and then the other deals with care plan decision-making tasks. And when you're taking a look at them, the level of ability that we have with the current technologies as it relates to these AI tools is in varying stages of development. Some of them are very, very immature or nascent technologies, these ones that are only shaded with one circle. These have to do with higher level thinking types of things, dealing with things like assistive diagnoses and clinical evidence summarization or generalization, all the way up to more mature use cases where we're dealing with things like clinical chart documentation and personalized care summaries. And we'll dive a little bit more into some of these things as we go. Go ahead and hit the next slide for me. For quite some time, clinicians have been using text to dictation as part of their workflow. some people have historically just used a straight dictation where you record into a dictaphone. That dictation is then sent to somebody that does transcription, and that's put into your note. That's always had some advantages and disadvantages. One of the advantages being that's a transcriptionist that's used to you understands what it is that you're looking for and how to structure your note. When you deal with a technology version of this, the most commonly used one that we'll see with this is going to be Dragon dictation. This does speech recognition and voice recognition. These things convert speech into text for clinical use. Go ahead and hit the next slide for me. This has certain advantages and disadvantages. It is fairly accurate in what it does. It's cheaper than medical dictation often, or employing a medical secretary, and the accuracy errors are typically just typos with this. Often, Dragon Medical is EHR agnostic, so that means regardless of what electronic health record you're using, most of the vendors support something like Dragon Medical, and you can generally use the text to dictation directly within the EHR. Some of the disadvantages that clinicians will have with these these dictation to text tools is that there's no learning component. The Dragon Medical is going to make the same mistake based on what you say every single time that you say it, unless you take the time to stop, change the input, or change how it's recognizing your input. And then go on and continue on through doing it. These are also asynchronous dictations, means that you're getting the information from the patient or from other clinicians or other staff, and then you're regurgitating that information into a usable format for the dictation to text instrument, which is then inputting it into your note. Also, if there's a failure of transcription, there's no record of this having occurred. So you might dictate a wonderful long paragraph and then get to the end of it, and the machine fails to register any such text, and then you're left to try and remember everything that you just spent the last 2 minutes talking about in order to get it to re-input. Okay, we'll go to the next slide. And so this really brings us to the next stage, which is how do we make these dictation tools better? And that's where AI come in. And these are ambient AI tools that have reached the marketplace and en masse now. And they aim to leverage speech recognition and voice recognition, but now start to use something called natural language processing, which means that it's actually understanding, based on the likelihood of the speech that you use, what other words should be coming next, or what other inputs you should be looking for, and how to structure the information in a readily digestible format for other people to look at. These utilize machine learning and large language models, as Jim and Suraj have already talked about today. And what that allows us to do is to be able to use these very large repositories of knowledge, and then utilize machine learning so that the algorithms can learn from themselves as time goes on. These are designed to document clinical encounters effectively in real time. So as you're working with the patient, obtaining a history, the ambient AI scribe is getting that information, putting it into the correct parts of the note, and summarizing it for you when you're done. Go ahead, next slide. Now, these have disadvantages and advantages as well. The training takes time up front. So whereas a Dragon Medical, you can pick up and start to dictate right off the bat and have the dictation instrument input everything that you said directly into the note, training an AI scribe has an upfront cost of time investment. So you have to take the time. You can take 100 of your own previous notes, as Dr. MacDonald mentioned, and you can feed it into these AI scribes so it gets used to the way that you use phraseology, your tone, your tenor, and it can make your notes mimic those styles. But that there's a cost up front to doing that. Sometimes you have the disadvantages of a conversation being misconstrued. If an ambient AI scribe is listening to a conversation, what you might perceive as just to be banter or medical terminology might be misconstrued as the other. These things are still subject to AI hallucinations, as any other large language model might be, meaning that it can make up information too. So you really have to be diligent about checking the notes when they have been transcribed by an ambient AI scribe. You can't just assume they're all going to be correct. There may be more privacy concerns, and I'll have a separate slide on that coming up in a second. The same thing as vendor concerns as well, and I'll go over what I mean by that in a moment. Accuracy errors here are not just typos. They might change the entire meaning or context of a note. And they have a disadvantage as they might not be embedded or EHR agnostic. These tools right now are by and large separate from EHRs, and you have to take a note and import it into the EHR. These do have advantages, which we're hoping that they will be better than anything we've had up to this point, and that they're learning models. They'll continue to get better as we continue to train them. They're real time, so you don't have that obtaining the information and then regurgitating the information again. They can distinguish between banter and medical information, just not always perfectly. They can put correct information into correct note component as opposed to you doing it manually. So you won't have to necessarily say, okay, this is a history element, this is an examination element. Through the machine learning algorithms, it'll be able to predict whether it's a history element or an exam element. And then it also oftentimes records or makes a transcription of what it is that you said to help with learning, but that also means that you don't lose dictation that you've given. So once you've said it, it really does still exist and you can go back to it. Go to the next slide. If you're going to be evaluating AI scribe tools, there's a number of components that you want to look at. You want to take a look at their accuracy and consistency, and that's not just based on the vendor data. You want to try them out in real or imagined patient encounters to see how well they perform. You want to look at the availability and scalability of these tools. So is it something that you're using as an individual clinician, or are you instituting it across a practice, or are you instituting it across a large institution organization? The cost, most of these have a recurring monthly cost. How adaptable in learning, what is their mechanism for continuing to learn as you're going? Is there a component that involves patient interaction piece? And then how does it handle data analysis and insights? Are you actually able to integrate with some of the knowledge bases that exist out there so that in real time, not only is it taking in and recording the information and putting it into a note format, but also then taking it to the next step, which is now also pulling in relevant references where you might be able to say, okay, if we're trying to deal with, an average 50-year-old person that's coming in for routine health maintenance, is it already pulling in what you should be doing as routine health screenings based on the age and gender of the patient? And then privacy and security issues. How does it handle in privacy and security? Most of these AI scribe models are going to be HIPAA compliant. However, you still have to understand that there are other privacy and security considerations, especially because most of them are not going to be embedded in the EHR. Go to the next slide. There's a data ownership problem. So for people that currently use other devices in the medical world, like for instance, Butterfly ultrasound, handheld ultrasound, you understand that your data might not be your data, and Epic too, for that matter. Your data might be owned by the company. So even though you might be capturing this data, you might be capturing the ambient AI scribe information, the company itself can use that data however they choose to use it. So they can collect and analyze your data. They have the right to monetize your work and your patient's data. You're paying to train their model. That means that you're paying a monthly fee and they're actually ending up with a better model because of it. So, they're essentially being paid to train their model to work better so that they can sell it for more. And what you want to evaluate is whether or not there's on-unit processing versus in the cloud, and some of the things that might occur with data ownership around that. Go ahead and next slide. And with the vendors, as Jim had mentioned, there are so many new players in this world of AI. Every month or two, there's new vendors entering the marketplace. You really have to be very aware that, especially with the large monolithic EHR companies that are out there, with Epic now being over 50% of the market share, there's going to be this battle for who is going to be able to be supported by these EHR vendors. And the vendors themselves will have incredible control over which tools might hit the marketplace. They have to, what they call, open their APIs. So that's the the back end piece that the EHRs use so that these scribes can become embedded. So if you want an AI ambient scribe, be able to take your information and input it directly into the chart, the EHR vendor has to permit that to occur. And none of them want to work with 700 different AI scribe models that are out there. So they're going to pick and choose a few of them that they're going to open their APIs for. And you have to hope that you chose the right ambient scribe on the front end piece of it. Otherwise, you're going to be training a new ambient scribe every couple of years until they settle into what is going to be market dominant or what's going to be good in the field. AI scribes also have their function. They only have the function that's permitted by the EHR right now. And its infancy, it really deals with the information gathering piece, the history, the examination, the assessment and plan, without being able to do things like order creation and signing off, medication queuing up. So you might be able to say to a patient, I'm going to start you on doxycycline 100 milligrams twice a day for a week. And it might be able to put that information into the assessment and plan very well. But where they have not, most of the EHRs have not yet allowed the functionality is for the actual creation of that prescription queued up inside your medication inbox to press the sign button, send to the pharmacy. Most people believe that those are going to be separate paid features that the EHRs will charge for, but we're still not at that spot yet. Okay, next slide. Last, we do want to make sure to focus on, and I think we've all tried to talk about some of the positives and some of the potential negatives and downstream consequences too. The AI ambient scribes have the ability to be able to take information and input it into the chart. And at the same time, especially as we start to get into the analytics portion, it's really important that we understand that garbage in, garbage out. These things bring their own or our own biases along with them. They may not be able to handle things like accents well. Some of the AI scribes report that they're able to perform good and accurate information gathering and transcription in multiple languages. However, it doesn't always translate the same way that you might think. Limited training data may not encompass a diverse patient population that can impact AI accuracy. Not a lot of these AI scribe models are being trained in medically disadvantaged or under-resourced communities, and that might change the way in which the AI interprets the information being presented. Bias and data used to train the AI can perpetuate existing healthcare inequality, so please keep that in mind. The cost of AI scribes may limit access for underserved populations in clinics, especially if you're dealing with a model where you might be wanting to have both the clinician and the patient being able to interface with AI. Not just the cost, but also the ability to use technology in a readily accessible way. Some of these models, even though they are oftentimes purport to be very user-friendly and easy to use, there's still a cost of utilization that might be higher than what some of our medically disadvantaged patients might be able to do. So they might not get the same benefits as some of our privileged patients might be able to. And there's lack of culturally competent AI interactions could lead to this patient alienation. So they might feel further left out by this digital healthcare transformation. So everybody might be talking about like, oh, I'm getting really great care because the doctor's using the AI and we're working on it together. And for people that don't have as much technological savvy, some of our more mature patients or some of our disadvantaged patients, they might feel even further left behind. So, okay, that's all I've got for you.
All right. Well, thank you, Dr. Matuszak, Dr. Achar. I'll bring it home, and we're leaving some time for Q&A, but I wanted to leave you all with our desire is to incentivize some of you who may be showing up and maybe a little bit naive. I just mean in the sense of like, I'm interested in things, but I don't know much about them themselves. That's why I tuned in tonight. You can train your own neural network. And that's certainly what I did over the last year or two. I just became interested in this, and I found many like they're freely available resources. So one I listen to religiously once a month New England Journal of Medicine AI Grand Rounds comes out once a month and has it captures so many dimensions of this world, including stuff we didn't even touch on today, including like diagnosis. And there are books and journal articles. The New England Journal of Medicine AI. There's a journal, let alone the podcast Grand Rounds. Before people logged on, Dr. Achar and I were talking about a recent JAMA Open Network study on diagnostic reasoning. And so I keep my eye open, or in PubMed, you can, of course, curate articles to alert that certain articles are being published. JAMA has its own little on its website, like a little corner that's always devoted to new AI research. So that's a way you can do it. AAP and AAFP webinars are freely available and are very good. And hopefully we'll have more of these kind of webinars in AMSSM. I bet your hospital system may have this, but Nationwide Children's Hospital has an AI community once a month, both like a general user community, and then once a month, a more like deep dive. The computer tech geeks get together, and it's very useful learning from them, trying to learn a little Python. Then if you learn a little Python, you can have your OpenAI code for you, and you know what's kind of going on. And play with it. Talk with your colleagues and play with it yourself. Take these things for a test drive. We mentioned DeepSeek. Dr. Matuszak just wrapped up talking about, some issues. And I think Dr. Achar mentioned, accuracy. Like, I was just playing the other day with DeepSeek's DeepThink. So in other words, I could ask a question like, I have a 30-year-old with back pain and, this and this and this and that. So what should I be thinking? What's the differential diagnosis? And it pumps out a differential. Or I can use the DeepThink format, which actually walks through the reasoning that the AI is using. It's brilliant, and it's totally new to me. So just play with these things. We didn't even touch on things. I'm now on a systematic review with what's NATA, National Athletic Trainers Association, the Journal of Athletic Trainers Association. We're using Ryan to help us slog through the thousands of titles and abstracts. You can download this awesome app onto your phone, Open Evidence, which if you have an NPI number is free to physicians in the United States and help you in the room right now with diagnosis. And then there's even free, basically you don't have to spend, if you don't have, if I were a private clinic and I didn't have to worry too much about, HIPAA issues, have my hospital weigh in, Doximity gives you a free way of having an AI scribe. So remember, adult learning works like this. If you're interested in anything we talked about, follow your intention, make this thing a habit, start listening to podcasts, play with these instruments. Pretty soon, before you know it, this is going to become part and parcel. This is our world. We have created AI just like Geppetto created Pinocchio. Pinocchio's looking back at us. Our creation and we are going to move forward in this world. Don't let it master you. Make sure you're the master still. And here are some resources, references we referred to. I'm going to stop sharing, and we're open for Q&A.
All right, before moving to our Q&A panel, I'd just like to express our gratitude to our distinguished speaker panel for sharing their knowledge and insights on using AI from personal experience and in their practice. I'll now serve as the moderator for our Q&A. So if there's anyone who has questions, please type them in to the chat box and I'll ask the appropriate member. Well, I'll go first here. I had a question actually, and just feel free, anyone, to answer it. We talked a little bit about AI and how we see the job market possibly being affected. Now, my question to you all is, do you think there are certain specialties? I've heard, radiology apparently is getting scared. What if AI takes our job? It's a lot better at detecting things on graphs. Do you think there are certain specialties that are more prone to having AI take over or push them out of a potential position?
I think you hit on one, Bill. If I step back for 1 second, I would say most physicians, I don't think, need to worry so much about their jobs being out, but they will need to be facile with these instruments if they're going to remain competitive within their specialty. So I'll give you an example. Like pathologists will be using this a lot. And if there's somebody who's not comfortable with these instruments in the world of pathology, they're gonna be falling behind. I think you hit on the one that comes the most immediate to mind that may like be threatened, and that profession, as I understand it, is threatened even before all this with like outsourcing to India, which is why I think most of my radiologists double down on the interventional piece so they can maybe, you know, make sure that they have job security. I don't think we will face that. I think primary care, it's still going to be, no question this is just going to change our landscape, but we are not going to be out of jobs because of these devices in primary care, I think.
Absolutely. And so we have a question from a Brian Williams. It is, how can we address concerns about AI-driven medical errors and ensure proper oversight? Is there something that government needs to consider as they look at AI regulation? And anyone can feel free to answer that as well.
Yeah, no, those are great. That's a gret question, Brian. You know, and really, even even more germane to many on this call might be how do malpractice carriers feel about medical errors related to the use of AI in the clinic and proper oversight, and how defensible is it going to be in medical malpractice cases? And who is really to blame if there's an error that occurs because of the use of one of these large language models that might have hallucinated an answer, and you're on the witness stand, and it's so so new, and I think that there's two approaches that you can take. One is that the industry figures out that their own oversight and their own rules and regulations related to it, and the other that government gets involved in helping to craft those with the idea that it's in the best interest of the people of this country in order to create those oversight rules. And obviously, those are two very different and diametrically opposed forces in this country when it comes to how to consider oversight of any new and emerging technology. So, yeah, it's going to come. It's got to come from somewhere. I think that, you know, as practicing physicians, we would probably prefer the option that protects us most. And I don't know that that's going to be the industry one. I think that government oversight is probably the better for our field, and for the people that are driven behind the technology. I think they would want to avoid any government oversight. So I know that's the dance around the answer to your question, but that's kind of, you know, that's the best I got.
My guess, if I had to say something about this question, is we are all going to be using augmented intelligence together. And it's obviously augmented intelligence hallucinates. We've seen it, but so do human beings. And it's very similar to how we sometimes see things that are not there. The computer can see it that same way. And that's why instead of just a computer and a patient, we're going to see computer, patient, and physician working together. And that combination is going to be better. It's like anti-lock brakes and safety features and technology in cars have improved safety. The same technology is going to improve safety in medicine, help us make our diagnoses sooner. So the ideal thing is not to delay diagnosis till the condition is too late. And so this technology is going to help us and help our patients and help us with communication to each other in a way. I actually see AI as also teaching us how to be better clinicians in so many ways, and how to better communicate with each other. So I see in medicine, it's like 95% positive. I don't see too many downsides to this technology. And I do see the hallucinations, and I've been struck by them. They're very odd. But what's remarkable is you can detect them pretty easily sometimes. You can see, like, you're dealing with a carpal tunnel patient with carpal tunnel syndrome, and the hallucination talks about something to do with a shoulder rotator cuff repair, and it's obvious that it's not there. But many times the opposite happens, where the AI technology, generative AI, helps us see things that we might not have been able to see the fracture, that we didn't know was there, see the pneumonia, identify that, or detect and maybe give us a better differential diagnosis of the problem. So I see this as, in a way, a win-win for both of us.
If I just followed up on one thing Dr. Achar just said, I think you hit the nail on the head that hallucinations are not always bad. And in certain contexts, you don't want them, right? As far as your accuracy of your chart note or what the patient said, or that the Packers have won 4 Super Bowls. I mean, dang it, I want that. But in the world of like drug discovery, hallucinations have been what have led some of this. Some people are familiar with that idea. Like there have been some drugs, new antibiotics that have been found that have completely taken a completely new approach to, I'm just making this up, like, like antibiotic resistance to pneumonia. And it came from hallucinations, like otherwise more or less what would be garbage in another context. This was a useful thing that the AI device provided. So like hallucinations are in some ways, I would say, a value neutral thing. You could maybe even just call them dreams, AI dreams, maybe.
Well, yeah, I mean, like there you go, old Blade Runner throwback, right? Or maybe it's the computer version of Alice in Wonderland. But I saw another question come up. I did want to make sure we got to touch on because we've only got 2 minutes left, and I had a good one here for you, Mark. When I said you put in there about Google Notebook LM much. Are you using it integrating creating educational materials for med students, resident, and fellow as well? I'll tell you that. So I took the Healthcare Administration Leadership and Management Board exam back in November, which is a brand new board exam being offered for the first time ever this year. And there is no known curriculum for this home board. There's no practice questions anywhere or anything else like that. So I developed my own study materials from using these large language models, developed the whole curriculum to study from 200 practice questions. And after some refining, because the first time around every answer was C, and then the second time around they just weren't hard enough. But after a few versions, like I got like 200 practice questions, which ended up being like pretty darn close to the types of questions that I actually saw on the board exam. So I'll let you know in February when the score comes out how well we actually did with using a whole curriculum generated from AI for a test in which there was no known curriculum right now. So
that's very clever. I love that. That's exciting. Well, Bill, do you are you
Yeah,
going
sure.
to bring us home?
I'll wrap us up here. Before we conclude tonight's webinar, I want to encourage you to join us Thursday, January 30th at 8 p.m. EST for an SMRC webinar radiology review featuring one of our affiliate members, Dr. Joseph McGinley, who is a highly accomplished diagnostic radiologist, speaking about radiology, an entrepreneur based in Casper, Wyoming. He is the owner of McGinley Clinic, where his practice specializes in MSK radiology and sports medicine, with a particular focus on non-surgical treatments for sports injuries. It has been my pleasure serving as the moderator tonight. I'd also like to thank everyone attending tonight's seminar. If you have any questions any further questions, you want to email, all of our speaker panel is available at some point. We appreciate everyone and thank you guys for sharing your expertise with us tonight.
Thanks, everybody. Really
Thank
appreciate
you.
it.
Bye, Lauren.